Can we have Dr. SWATI?
Your
By
mask.
Dr. Sachdeva on optic neuritis.
Take off your mask.
Much has changed in optic neuritis, but not much has changed as when the traumatic optic neuropathy is concerned. So it's just an overview of what we already know about traumatic optic neuropathy and where we can actually make a difference. So to begin with, traumatic optic neuropathy is a vision-threatening condition and is caused by ocular or head trauma. Facial trauma and closed head trauma are the most common causes for it, and in around 0.7 to 2% or up to 5%, it can be associated in all causes of trauma. There can be a direct nerve injury or an indirect nerve injury. So direct nerve injury is one where there is an direct anatomical disruption of the optic nerve, which is associated with injuries to head, face or orbit. And this forces, when there is a blunt injury to head of or directly on the brow, these forces are transmitted to optic canal, causing the fracture of the optic canal, which can compress on the optic nerve and cause traumatic optic neuropathy. This can also be because of the projectiles. If it's a penetrating trauma, so certain foreign bodies or certain projectile can get lodged in that area and can damage the optic nerve. The indirect injuries is little different. It is again by the forces that are applied to the bony orbit or to the head or to the area around the brow, and because of the tight adherence of optic nerve at the optic canal, there is a kind of acceleration deceleration forces and leading to concussion injury, leading to mechanical shearing of retinal ganglion cells that causes an irreversible neuronal loss and loss of vision. Here the most common site of injury is intracanalicular part. Why? Because it's the most fixed part, the immobile part of the optic nerve. Sometimes you may see the hemorrhage within the optic nerve sheath, or there may be hemorrhage in the orbital cavity. And this hemorrhage compromises the circulation of optic nerve and may result in compartment syndrome. So this is where probably a surgical intervention may make difference. Coming to clinical features, the patient will present with the classical history of blunt trauma, which may be actually on the brow or somewhere in the on the face or maybe forehead. The presenting visual acuity is generally very poor in around 60% of cases. Many of them may present as low as no PL as well. If the vision is good at all, you may have loss of color vision and contrast vision. That will depend on the severity of injury. Sometimes you may see that there is a contralateral eye involvement also, so you may have a poor color vision and poor contrast sensitivity in the other eye also. Presence of RAPD will be there as with any other type of optic neuropathy. Proptosis and disc edema may suggest orbital hemorrhage, so one should look for it actively. So if the injury is anterior enough, it may actually cause optic nerve avulsion, which may be seen as a ring of hemorrhage leading to retinal infarction and central retinal artery occlusion. More posterior injuries, the fundus may actually be normal, and this pallor develops around 6 weeks of the injury. Coming to investigation, so like in any other setting of acute trauma, CT scan here is the treatment of choice vis-a-vis in other optic neuropathy cases where you want to do MRIs. So it's important to do CT scan with fine cuts and axial sections of around 1 to 1.5 mm to rule out optic canal fractures, to rule out optic nerve sheath hemorrhages. MRI of orbit, if at all done, may reveal a focal edema of optic nerve or optic nerve sheath enhancement with gladinium. So if at all one has to prognosticate the case, maybe VP and electrophysiology in form of ERG will help. So if the studies have shown that if the amplitude is less than 50% in a unilateral cases, if you compare the two eyes, if the amplitude is less than 50%, it is suggestive of poor prognostic signs. Similarly, for electroretinogram, if the waveform is flat or of low amplitude, suggests again the poor prognosis. Coming to management, it's still controversial. The role of steroids, role of surgical decompression, everything is controversial. We don't have a definite treatment for traumatic optic neuropathy till now. It has been reported that around 25 to 50% of cases may improve on their own and could be of are maybe indirect traumatic optic neuropathy. And baseline visual acuity is the most important factor that can predict the final visual outcome. The cases which are associated with multiple orbital fractures or facial fractures generally have poor prognosis. So these are two studies which have been done and have shown the role of steroids. As I said, the National Acute Spinal Cord Injury study has shown us that probably steroids, if given in very, very high doses, as high as mega dose of 30 milligram per kg as a loading dose, followed by around 6 milligram per kg for next 24 years in a very early period, in a short window of say around 6 hours or so, may help in salvaging the vision, may help in salvaging the optic nerve. But contrary to this study, the other study, which is a corticosteroid randomization of significant head injury crash study, has shown us that mega dose, if given within 48 hours, can actually cause the worsening of the mental status. It may increase the cortical edema and may actually result in death. So this study was stopped in between. So comparing all the treatment options, whatever we had, the International Optic Nerve Trauma Study was done, and they have seen the results with observation with high steroids and also with optic canal decompression, but they concluded that nothing, neither the timing nor the type of treatment, can affect the outcome. So there are very few, small subset of patients where actually surgical intervention may help, and one of the one of the most serious complication which can occur is orbital hemorrhage, and where your intervention, a small canthotomy or cantholysis, may actually help in decompressing the orbit. You may drain it also, and probably may prevent the irreversible loss of vision. Patients, if have any kind of impacted bony fragment impinging on optic nerve, doing a decompression may help. Intra-sheath blood, if it's convincingly, if you are definite that it's there, the optic nerve sheath fenestration may be indicated in such case. Thank you.
Any of the panelists would like to comment?
I think VER response has a recording is also very predictive in these cases. As Dr. Mahapatra published a very large series of patients, and he came out with the conclusion that if you have a positive response, these patients have a more chance of recovering the vision. Than the response is negative, then they are a very poor prognosis. So I think we are also a role in predicting the visual outcome in these cases.
Yes, ma'am. That's what I said, that if the amplitude is 50% of what is there in the other eye, maybe it suggests a good prognosis with a flat wave.
Also because of medico-legal aspect, which will always be associated with trauma.
Yes, that's true.
So one more thing that Dr. Mahapatra suggested was that if you find edema on the imaging, then there is a role of steroids. So even if the patient is coming, let's say, around a week, and you still see edema, in those cases, oral steroids he had given for 2 weeks, and those cases showed some improvement. So maybe just a decongestion.
Can I just ask with regard to the medical legal, is there any particular practice pattern that you follow when to treat with steroids, when not, or do you individualize it to the case in front of you?
Yeah, most of the time we do individualize, because there's no definite criteria when you want to treat or you don't want to treat. So as sir said and ma'am said, that if you have some kind of response on VP and the patient does not have any neurological contraindication, which is much more important because it may worsen. So in those cases, maybe steroids can help.
So
but
apart
not in
from
all
contraindication, the try.
Yeah.
Oral only. I mean, not high dose.
No mega dose. No mega dose for sure.
No mega dose, yes.
One point I would like to add. So we before giving steroids, all of us have to. You have mentioned about the crash study, and so whenever there is a simple rough guideline is to ask for any CS of rhinorrhea. So whenever they have a CS of rhinorrhea, it's better to avoid steroids because we have an open communication.
Indeed, yes.
So
point well taken.
totally better to avoid steroids.
Indeed.
And another thing, whenever there is a deterioration of vision, the patient is getting better, but it again deteriorates, it might warrant a repeat neuroimaging and perhaps a sheath decompression or a canal decompression. Yeah. So occasionally that situation.
Or even a CT scan to see if the bone fragment is impinging on the optic nerve. That can give rise to progressive loss of vision, except Padmavati.
Thank you.